Okay, welcome everyone. Welcome to uh, our WONCA Young Doctors Movement uh, collaborative webinar with Special Interest Group. Uh, this is our fifth uh, collaborative webinar for WONCA YDM with different special interest group of WONCA. So it's 9 already, so we will start our webinar today. First of all, I want to say Happy New Year to everyone. The Chinese New Year is coming in 10 days, and we will have a very big celebration and very big spring break at that time. So everyone is looking for it, and it's uh, the happy atmosphere is everywhere here in China and the Taipei. So I want to thank you everyone for joining us today. And first of all, we'd like to ask Professor Gu, the chairperson of the Special Interest Group of Emerging Practice Models for Family Medicine. Welcome, Dr. Gu. Please say something to us.
Yeah, thank you. Thank you very much for your invitation, Dr. Zhang, and dear Dr. Professor Donald Lee and other all colleagues. Yeah, it's a great honor for me to join us, and also we are very happy to be invited to have the collaboration for our SIG and also Young Doctor Movement. We work together and have this webinar. So the Emerging Practice Models SIG was founded in 2019 and by Professor Donald Lee and Professor Rich Robert and I. And the emerging practice model is an innovation of the traditional family medicine model. So due to the different culture and development between countries and regions, the model can have various forms. So today we also will have Dr. Pu Zhou will introduce some new model from Shanghai, from our Huashan Hospital. So we are very glad to have this kind of collaborations. And I think maybe we will have this new kind of emerging, also new kind of models after the discussion. So thank you very much for your invitation. And I think I wish this program will be very successful. And Happy New Year and also Happy Chinese Festival to you all. Thank you.
Thank you, Professor Gu. And next, we would like to invite Dr. Donald Lee, the founder of this, one of the founder of this Special Interest Group, and our previous WONCA world president. Dr. Donald Lee, please say something to us.
Thank you, and good morning, good evening to everybody. It's wonderful indeed to be here at this collaborative webinar with Raja Kumar Movement. It's one of the few series, but tonight, of course, we're very excited to be able to talk about a subject on emerging practice models. I'm excited to see that family doctors around the world are actively exploring innovative strategies to deliver high quality, personalized healthcare, from concierge medicine to groundbreaking digital health solutions. These emerging practice models are revolutionizing the landscape of family medicine. These new models, which encompass premium service and patient-centered care, aim to enhance access, improve quality, and promote preventive care. Importantly, they also address pressing ethical concerns related to equity and universal health coverage, ensuring that all patients receive the care they deserve. WONCA Special Interest Group on Emerging Practicing Models for Family Medicine is leading the charge in this vital conversation. Tonight, we have speakers who will share their insights from different parts of the world, from Shanghai, China, to Mexico, to Malaysia. We are all committed to fostering collaboration amongst healthcare professionals and establishing standards that will shape the future of primary care. I look forward also to hearing insights from global leaders in family medicine as we go into discussion and aid and pave the way for advancement in our field and also lead the way in transforming healthcare. So let us join together to inspire change and improve healthcare for all. So all good wishes for a very fruitful evening tonight. And like everybody else, a happy new year, wishing everybody good health and happiness. Thank you.
Thank you, Dr. Donald Lee. And I think it's very important here in Asia Pacific region because traditionally, family medicine is not a very widely adapted type of primary care in Asia Pacific region. In many countries, we actually are facing many difficulties, even establishing a formal association of family medicine. So I think it is a very important task for us to see the successful models from worldwide. So first of all, we'd like to invite our first speaker, Dr. Zhou Pu. Zhou Pu is a attending doctor in Huashan Medical Center and Fudan University. And she have a double bachelor degree in integrative traditional and Western medicine and applied psychology. And she has a master's degree in internal medicine, infectious disease. And her research orientation is international medicine, medical tourism, international general practice, and treatment and management of chronic liver diseases. And she is an executive member of WONCA Special Interest Group, emerging practice of models for family medicine, and also a member of International Medical Tourism Branch, Chinese Non-Government Medical Institution Association. Let's welcome her to present us with her topic.
Hello, everyone. I will share my slides online. You see clearly?
Yes.
Hello, everyone. I am Zhou Pu, a young doctor from Huashan Worldwide Medical Center, and also executive members of WONCA SIG Emerging Practice Models for Family Medicine. It is my great honor to have the chance to share the content of International Medicine of Huashan. So let me give a brief introduction of international medicine in China. So what is the international medicine? It's a kind of emerging practice models. International medicine, An international medicine is a medical service format characterized by high standard service and high-level technologies. The purpose is to provide patients with best medical experience and health protection. And international medicine has a specific target population. For foreigners in China, overseas Chinese, inbound foreigners with medical tourism purpose, and Chinese citizens with international medicine needs. So it also has a specific payments. First, commercial health insurance, then overseas medical insurance, and self-payments of cross-border patients. So what is the connotation of international medicine? The international medicine has stacked populations and medic management, has high quality standards and service facility and specific payment arrangement. So the coverage of international medicine is disease diagnosis and treatment with medical checkup and health management, vaccination, medical tourism, cross-border medical transport, multicultural medical service, as well as management of medical institutions, international commercial health insurance, and so on. So what is the development of international medicine in China? Since 1980s, with China reform and opening up, the demand of international medicine increased. The international medical service system began to form with establishment of international medical centers in several public hospitals, especially in some economically developed areas in China, like Beijing, Shanghai, Guangzhou. Now the medical institutions has expanded with high-level public hospitals, non-government hospitals, and clinic. So, next, I will introduce the international medicine of Huashan. Huashan International Medicine is a very representative existence in China's international medicine field. Huashan Hospital. Huashan Hospital set up in 1907 and has 117 years history. So it's ranked top 10 in China. Our hospital has more than 16.5 thousand hospital beds and with employees with 5,000. We have more than 5 campus and outpatient and ER emergency patients has over 1.7 million per year, as discharge patients over 118,000 per year, and surgical procedures with 80,000 per year. We also are teaching hospital of Fudan University. So Huashan Hospital has a very rich clinical specialties and disciplines with more than 15 clinical specialties. It's very famous for its neurosurgery, neurology, dermatology, infectious disease, and rehabilitative medicine, hand surgery. We also have cutting-edge medical technology and equipment. This is a strong backup for our international medicine. So, the international medicine of Huashan Hospital is mainly carried out by Huashan Worldwide Medical Center. It's our department. Our department, established in 1989, is one of the earliest international medical facilities in China and have provided service for over 1 million patients, with 50% of them from overseas, and provided service for over 16,000 commercial insurance patients. We have direct billing with a lot of international insurance companies and obtained GCI accreditation. So we offer the comfortable environment for patients. This is our Liu Building Clinic and Ward, brand Liu. We have 24 single rooms for inpatient and 24 single rooms for outpatient. All the outpatient can have complete most of inspections in individual floors like EEG, the ultrasound, echocardium, acupuncture, and rehabilitation treatment. We also offer a lot of medical services like inpatient rehabilitation, health checkup, vaccination, patient escort, and medic backup. So this is also the insurance corporation. We have more than 16 corporation companies, and our outpatient insurance clients and revenues percentage was nearly 80%. So we also build the system of international medicine. Our mission and vision, excellent medical care and exquisite customer service. Our system is patient-centered. So surrounding the patient is our department services, our medical team, medical service, murder, humanistic care, and medical facilities. And in the middle circle is the big, strong backup for our hospital. Hospital support, clinical specialists, cutting-edge equipment, and advanced technologies. So the outermost circle is support from the outside. So government, foreign exchange, and internal active health and insurance corporations help build our international medicine system. So the features of our international medicine of Huashan were patient-centered, with evidence-based care, multi-professional team, cutting-edge technology, home-like environment, multilingual services, and special payment, cost-effective, and respectful, culturally sensitive manner, warm, caring, attitude, confidentially. So in this system and our future, Huashan International Medicine have a GP team, and this GP team plays an important role in her medical activity and also constitutes our special model. This is the schematic diagram. For example, patients. If it's in our out clinic patients, first, our GP team, primary care, made a differential diagnosis according to the patient's symptoms and complaints and do treatment or refer to our specialist. So when the disease is stable or when the treatment regimen is established, we back up the patient back to our GP doctor. And for our inpatients, we build a common management model. So our GP doctor and the specialist work together to treat the patients. And this constructs a special Huashan model of international medicine, patient-centered, multidisciplinary, and closed loop. We can look. From front end is our sound visiting experience, smooth channel for referral. In our middle end is a team of our hospital experts, strong support of technology. Rear end is convenient channels for paying by commercial insurance. General practice and specialties work together to treat our patients. We have full range service and make an integrated health management. Okay, here, this is one of a brief presentation of a successful case through our model. A patient, a middle-aged male, diagnosed with liver amoeba disease. So when the patient admitted to our hospital, our general practice made the differentiate diagnosis and find a big occupation of liver. We coordinate the infection disease department to help us do the pathogen testing and arrange the gastroenterology department to help us do the gastroenteroscoping to final diagnosis these patients have amoeba infections. And during the treatment, when the liver abscess was too large, we also coordinate our liver surgery to do the surgical treatment for drainage the liver abscess. So during the treatment, the neurology, the patient has a large dosage of metronidazole, and the patient has a metronidazole associated encephalopathy. At this stage, we also coordinate our neurology department to help us. So during the whole process of diagnosis and treatment, our GP doctor coordinates the multidisciplinary special department to help us do the diagnosis and treatment. And we do the whole process comprehensive management, close contact with patients to any time to ensure good accessibility, and including the sustainability of post-discharge outpatient follow-up, and give a stress humanistic care for these patients. So there are many other successful cases like this in our center through our special model. This attract a lot of overseas patients come to our Huashan worldwide department. Last year, we have patients from over 86 countries and regions. And We are also ranked the #1 as the foreign inpatients in medical institutions in Shanghai from 2006 and 2020. We also generally recognized by a lot of international communities, appointed to be the healthcare provider for 10 consulates general in Shanghai, including Australia, Canada, Germany, and so on, and receive a lot of thanking letters. Huashan has not only established the international medicine models, but we are also the leaders of international medicine organizations in China. So our director, Professor Gu, hosted the first international forum of primary healthcare in China in 2008. And in 2010, we built the Society of International Medicine. This is the first organization of international medicine in China. And in 2014, we built a Regional Collaborative Committee of International Medicine. And in 2018, we built a Committee of International and Primary Medicine in Secretary of Cross-Strait Medicine Exchange Association. And in 2019, Dr. Du let us be a member of WONCA. We entered to the WONCA big family. And in 2023, established the WONCA SIG, emerging practice models of family medicine, and make the sound on the world stage for our Huashan International Medicine. These organizations plays a lot of roles. Not only in addition to setting up the organizations, we also play a leading role in our industry. Primary healthcare forum, we hold a national continuing education and suggestions for policymakers, make collaboration. Function 1, the platforms. Our organization organizing the International Forum of International Medicine. We also held almost 16 years consecutively holds our forum of international medicine. And we also made the guidance of national GP training program with international experience. So function 3, think tank. Research of international medicine. This is a very important thing because we also do a lot of research of international medicine, medical tourism, and health insurance. Last year, we built the Shanghai local standard specification for service of international medicine. This is the first standard of international medicine in China. We're committed to the formulation and the promotion of international medicine norms and standards. We also do the outward development. The Society of International Medicine's collaboration with foreign hospitals, academic groups, investment, treatment, intellect, consulate, and health insurance. And we also in the international medicine field to do the collaboration and coordinate with public hospital, joint venture hospital, insurance company, medical rescue company, health management, and so on. Establish the medical network for international and patients, and providing services for disease control, medical escort, referral services. And recently, to matching the policy and measures of Shanghai to develop the international medical tourism, we also do the overseas broad communication of Huashan International Medicine. I think it is innovative to start. As the first public comprehensive hospital in China, we made exhibitions at ATM in Dubai and conducted an overseas roadshow for Shanghai International Medicine in London World Travel Market. The achievements were reported by more than 14 well-known domestic and international media, including as the Shanghai Municipal Government website, China News Service, European Times, and cast on CCTV4 and CGTN. This is an international channel in our China for 6 consecutive days during the National Day period. So, international medicine is an emerging practice model. It has inclusively, openness, and integrity. Huaxian-specific international medicine model received unanimous praise from the industry, and we are continuing to keep making progress. Oh, that is my sharing speech, and thanks for everyone's listening. Thank you.
Thank you, Dr. Zhou. And I think it's really important. It's actually emerging practice model because now we are our community actually exceeds the geological dimension. Some of my patients, maybe they are even not in they are in another country. People are traveling around more and more frequently. So I think for family medicine, the definition of a community is not it's beyond the traditional definition of one specific location. So I think the tourists may need primary care in foreign countries. So I think it's really important. Is anyone have any question for Dr. Zhou? Okay, so I have a question. Do you do telemedicine in Huashan?
Right now we have not yet, but we try to do. I think telemedicine is a very convenient way to bound patients from different places, especially in remote areas. And if the patients want to do the medical tourism, if we first do the telemedicine, we can have some medical records and help us to make more accurate treatment and make a good medical service for this kind of patients.
Okay, thank you, Dr. Zhou. Okay, if anyone have questions but are not able to talk currently, you can also type in the message box. We can answer the question later. Okay, the next speaker will go to Dr. Wang Pingfu. Dr. Wang Pingfu is a family medicine specialist and the head of clinic at the Cheras Baru Health Clinic, Kuala Lumpur, Malaysia. He obtained his postgraduate qualification in family medicine from University Kembangan, Malaysia Academy of Family Medicine, and the fellowship from Royal Australia College of General Practitioners. And he completed his subspecialty training in primary care, non-communicable disease, and the area of interest in primary care of elderly. He holds many positions in many organizations and expert committees in primary care. He is one of the executive member at large at WONCA Asia Pacific region. He is our immediate past chair of the Rajakuma movement, and also an executive member of Special Interest Group on emerging practice models for family medicine. So he's both member of the two group. So let's welcome Dr. Pingfu Wang for his topic, Transforming Primary Care, New Horizons in Family Medicine.
Thank you. Yeah, thank you, Pingshun, for the kind introduction. I'm very happy to see our experienced seniors, Prof. Dr. Donald Lee and Prof. Wendy Gu here. And of course, very happy to see all my colleagues here. So basically, I will be bringing you to the different perspective. I think I want to thank Dr. Puzhou in sharing the international medicine in China. So basically, Malaysia, I think we have a lot more to learn from China and also other country in terms of emerging practice model of family medicine. So allow me to introduce Malaysia. I know some of you know Malaysia very well, and I want to say well done to Ping Shun. You are able to pronounce Bahasa Malaysia well, the clinical kesihatan baru. That is my practice. So it's one of the country in Southeast Asia, and we are actually separated by the. We have actually two regions. One is the West Malaysia, and we have the East Malaysia. So it's actually separated by the South China Sea. And for East Malaysia, it used to be called Borneo, the Sabah, Sarawak. And of course, in West Malaysia, we have a few countries, a few states in Malaysia. So if in terms of geographically, I think you want to talk about equatorial line is actually at the equatorial line means that we do not have the four seasons like some of the country. So Malaysia is hot and humid, and cover the area of almost 330,000 square kilometer. And regarding our population, we have, if you try to refer to the figure in the darker blue, 30 box in the darker blue, so 34.1 million at the moment, not as big as China, of course, not too small as well. And we have, if you can see from here, our population by gender, we almost reaching the equal. Once upon a time, there was a lot of male, female compared to male. Nowadays, I think it's almost equal, I would say. And then you can see from here, the sex ratio is 1 over 100 female. Okay, so median age is 30.9 years old. And we are multinational, multicultural, multi-ethnic country. We have the Malay at the Bumiputra. We also have other Bumiputra, like those indigenous living in the Borneo, as well, and in the East Malaysia. So we have Indians. Of course, we have Chinese. So Chinese will be the second, and then subsequently you have Indians and others. And our population by age group on the right-hand side, you can see the dominate by the middle age from the adult 15 years old to 64. Okay, so we are actually aging country, but we are going to achieve age country by 2030, which is another 5 more years from now. So what is the Malaysian healthcare system? So we have, like most country, we have a dual system, and in which the public will be the main system in which our population go to. We also have the private sector. So the public would say, we cater most of the patient or most of the population, and at the very, very affordable rate, in which most of them can pay only 1 ringgit to have access to the public primary healthcare service. So as I said, it's a government funded, and then a lot of these government funded are actually funded by the tax money paid by the citizens of Malaysia. And we also sometimes for private sector, it's actually fees for service. Basically, patients have to pay out of pocket. At the moment, we do not have any financial scheme, health financial scheme, but at the moment it's voluntary. And we, of course, we have achieved the universal healthcare coverage, and these have been this dual system have been coexisting for many, many years since Malaysia achieved the independence in 1957. So we provide both the acute and chronic care, as well as the urban and rural care. So this is just a very busy schematic overview of Malaysia healthcare in a nutshell. Okay, I will not go through this in detail, but I think it's very important that primary healthcare is the trust of any healthcare in any health care system in any country. So of course, primary care at the base. Prior to that is a population-based care, and then subsequently we have the secondary and tertiary care. So in Malaysia, any doctor can actually refer in the private. I'm talking about private, can refer to from primary can go to tertiary, or patient actually can straight away get treatment from the private tertiary care and secondary care bypassing the primary care. So that is happening in the private side, but for the government side, we usually will go through the primary care, then if needed, the care will be escalated to the secondary and tertiary care. And this is the just to show you the structure of the government primary health care in the 90s. After we attained our independence in the 1957, and subsequently we have current from 1970, which is in which we have the main health clinic and we have the community clinic. And again, this is to tell you how busy is a primary care. And this is a scope of services over the years given by provided by the primary care in Malaysia, especially the government side I'm talking about. So in the 1960s, I think in many countries, we pretty much focus on the maternal child health. Okay, and subsequently, I think we have expanded and extended our services. So if you can see from here on the right, just bear with me. This is some Malay language here. So on the right hand side, we have so many services at the moment. So some may wonder, how do we classify our clinic, the government clinic? So basically, we classify our government clinic. There are 7 types, mind you, 7 types of government clinic in Malaysia, based on the services provided, based on the so-called patient load per day, as well as based on the type of the clinic. And when I say type, means that whether it's a modern type or whether it's the old type, that kind of thing. Of course, this is the when we say we have type 1 to type 4, that is where the resident FMS will sit. And if let's say type 5 to 6 and 7, usually the FMS will visit that particular small clinic. And things have changed. We felt that we need to further divide, because sometimes it's very hard. Some of the clinic, the government clinic, we call it KK. It means it's Klinik Kesihatan Health Clinic in government. So basically, this is we have further divided. If you remember, that's 1,000 above. It's actually type 1. So we have actually further divided from 800 to 1,200. That kind of, so that we can actually further put in our manpower. So this is the projected need of the manpower for each of the type of the Klinik Kesihatan or health clinic in government setting. Okay, so now we have most total of 2,840 clinics, government clinics in whole around Malaysia, including the rural and the urban area. So of course, I think we all know Malaysia have achieved universal health coverage many years ago. And because my topic, I will focusing on the transformation. So basically, we have this as many as like other country. Singapore have the healthier SG initiative, but we in Malaysia have the health white paper. So basically, the development of our health white paper in 2023 is very what we say is very important, because over the years, I mean, we have changed a lot of government. So Malaysia, the Ministry of Health has actually done a lot of system analysis and reform recommendation, and which have not take off because of sometimes I think we know that sometimes it relates to political view. However, we have actually managed to get that health white paper endorsed by the Parliament, which that is a bipartisan endorsement, in which that health white paper will be carried on whether whoever rule the Malaysia, whether any party political rule the Malaysia. Okay, so these are the few challenges. I would say some country may share the same challenges with us. Maybe some country may have the different challenges. So these are the challenges. We all know increasing of the double burden of the disease, in which we have the non-CD and CD, non-communicable and communicable disease. Not only communicable diseases, we also have the re-emerging of communicable diseases. Okay, and then I think we COVID-19 has actually tested the healthcare system integrity, and whether it's resilient or not to face another, for instance, COVID-18 or COVID-20 or that kind of thing. So these are the few challenges that we face. And of course, we do have some imbalance of human resources, in terms of health facilities and also medical equipment. Of course, again, as I mentioned earlier, our health system, in terms of financing, we are pretty much sponsored by the government. Malaysian just pay RM1 to get the service, and because of this, I think sometimes it leads to some health finance constraints. And of course, we have a lot of demand in terms of increasing health services. Malaysians are growing, and then thus I think we need the really up-to-date services for our people of Malaysia. And we all know the aging population is coming, as I mentioned, and also the impact from the social determinants and health and also planetary health. Okay, so this again, just to elaborate further, as I mentioned just now, Malaysia is one of the I would say the country who has the highest obesity in the region, and almost like 64% of our patient or of our population are obese, and there's nothing to be proud of. Of course, I think we also face a lot of increase in other NCDs like cancer and even mental health, affecting not only adult but also as well as the children. And as I mentioned just now, we have the emerging and re-emerging of communicable diseases, and we do have sometimes outbreak of polio in certain areas. Of course, aging population, and we know that with aging population, the medical expenditure will be increased 2 to 3 times more likely than the average adult population, and higher costs and everything. It's just that the question is whether Malaysia is ready for that. And social determinant of health, I think we all know 20% is managed by the healthcare, whereas the other factors that determine the social determinant of health will be socioeconomic factors, physical factors, and health behaviors. So with healthcare only can managed by healthcare 20%, but we know 80% that make us healthy is actually determined by what is happening outside the clinic. So, and Malaysia, even though do not have a 4 season, but sometimes we do have haze, we have floods. Of course, we cannot run away from modernization because of that, they leading to deforestation, and sometimes we have landslide. Of course, sometimes we have this. In 2019, we have this pollution, chemical pollution, in one of the area in Malaysia. And then financing is very important. Our current health expenditure is only 4.1% of the GDP. I think we all know the best is still 5% above, but having 4.1 doesn't mean that we have the 4.1, because with the 4.1, it further break down to 2.2. Public sector is only spending 2.2. We should be spending 5% of the GDP rather than 2.2. And we can see that there is a lot of out-of-pocket spending. It means that there's no insurance, so population, citizens of Malaysia have to pay out of the pocket, to get the service from the care from the private side. And we do have some clinic have overcrowding, long waiting time in the public clinic, and many old facilities that need to be upgraded. And sometimes we have maldistribution of health resources, and we always face health personnel. No doubt, the Ministry of Health have been trying to their best to optimize the number of the health personnel. So what is the aspiration of Health White Paper? This is our aspiration. So we want to build a so-called nation, a healthy nation. We all know that we want to shift the care from sick care to health care. So basically, so that everyone is sharing the responsibility across the sectors. We know healthcare is about a big thing, and everybody should have the responsibility. And we want to have a healthcare system priced and valued by the population. And we want to have an equitable and person-centered healthcare system, a resilient healthcare system, and an open, innovative healthcare ecosystem. So these are a few priorities. The priority was given to the primary healthcare, and they want to give a greater emphasis on preventive and promotive care, which is, I think, in line with what we are doing. And of course, other than that, they want to strengthen the public health function, including the high-speed preparedness. And the third one would be a new social contract, and as well as the investment in health and decreasing the out-of-pocket spending. So we have 4 pillars. This is the 4 main pillars: transforming healthcare service delivery, advancing health promotion and disease prevention, ensuring sustainable and equitable health financing, and strengthening, lastly, is strengthening the health system foundation and governance. So how to do it? This is just an overview of each of the pillar, in which the strategies implied at the below of each of the pillars. So I will just quickly just go through what are the proposed solutions for challenges that we are actually suggesting for primary care, in which we want to outsource the healthcare services to private and sector. Of course, this will refer to the specific essential services, and then we want to have a proposed in terms of strategic purchasing for healthcare across the private and public sectors, because we do know that there are private sector around. It's just that now they are only seeing, like for instance, the Ministry of Health seeing 80% of the chronic cases, but they only seeing 20%. So we can see that there is a disparity in terms of the burden of the healthcare. So we want them to come in, and we want to purchase their service, so that they can actually help to see the patient. So so on and so forth. And then what is more important is to have a efficient provider payment mechanism. So it can be in a fee for service or capitation, or pay for performance, and mixed payment. So we also, of course, want to focus on the primary healthcare for prevention and promotion towards healthy aging, and giving autonomy to the primary care facilities, okay, whether it's partial or full autonomy, to manage their own clinic. So I will just quickly go through. I think I will bypass this. This is just elaboration on each of the pillar, particularly in pillar 1 and pillar 2. But you can actually go to, focus on what I have putting in green, the box. Okay, so basically, when the health services at the primary healthcare can be further expanded. So we want the ambulatory care to be slowly shifted from the hospital to primary healthcare settings, and every person will be registered to an accredited primary healthcare provider, and the team will be a multidisciplinary, and subsequently we want to have a better or coordinated care across the different sectors and levels, both the public and the private facilities. And we also prioritize, put in emphasis on virtual and teleconsultation. We want to improve the access and reduce the need for physical attendance to the primary healthcare facilities. And in terms of others, this is the midterm, the underline in blue. So enhancing partnership between the private sector and of course, further digitalization initiative. And we want to optimize the human resource and the infrastructure. So again, this is a few of the suggested implementation strategies. For pillar number 2 is regarding the advancing health in promotion and disease prevention. So so currently we have a lot of screening going on, whether it being public or being private or NGO. So sometimes these are too many screening. So a same patient can go for so many screening. So we felt that sometimes it's a bit wasted. Okay, so now we really want to make sure that there is what we call standardized essential services appropriate for the age in the national screening program. And then we want to increase the coverage, make sure those who have not done the screening will be given the chance to do the screening. And then also at the same time, we want to have an appropriate screening interval according to needs, in which a patient who have been screened and then found out to be good, and then maybe we can actually, for those are very low risk factors, practice very healthy, maybe they can be delayed, the interval of screening, so that we can focus for those who are really need. And of course, with this screening, I think it's very important for us to have an integrated system. Besides, as I told you just now, a patient may go to a few centers to do the screening. So we only, with this integrated system, the other healthcare worker who are in the other center will be able to know whether this patient had done the screening, and at the same time they will be able to review the result. Okay. And of course, I think we all know in terms of the NCD, Okay, behavior plays a lot of important part, okay, as mentioned in the social determinants of health. And of course, I think personalized care will be very much important. Primary health care at the platform in terms of for promotion and preventive services. And also, we are thinking of putting in powerful nudges, because sometimes people need nudges in the way that we need reminder to be reminded, So this can be done by having an application. We do have My Sejahtera is an application that we use for COVID-19, which has expanded for health screening. So in which, let's say, this patient who actually due for his screening will be receiving a nudges or maybe a reminder for him or her to do the health screening. So I think they will be reminded on their appointment as well. So of course, I think other than that, active registration on tax on unhealthy consumer goods, I think these have been practiced, and also pretty much important, the intersectoral collaboration, coming together with other agencies so that we can actually provide better care for the patient. So this is just some of the example that we have done. One is prior, before the health white paper in 2023, and subsequently, these are the few programs that we are actually extending to, in which we have this enhanced primary health care, one of the model that we have been doing. So we have been tested since 2016, 2017 up to 2021. So subsequently, I think we are actually expanding. So what is different from other type of clinic? So clinic, our government clinic with this enhanced primary health care basically have the liberty of providing better care to the patient. How does it done? So maybe I will just quickly go through some of the benefits here. Okay, if you can see short term and the long term. So our aims to be able to detect early and screen early and treat early and manage early. And if let's say there is a patient is needed referral early, then we need to be patient need to be referred early. If you remember earlier on, I told you, there is a haphazard in terms of referral, patient can go everywhere. So we want to really make sure that the referral system is on par, and then seamless referral system, and also counter referral from the secondary and tertiary care, and at the same time want to improve the defaulter rate. So of course, with this, I think we hope to reduce the morbidity and mortality of NCD and reduce the healthcare cost for NCD. So how to do this? Okay, so we can do it by, as I mentioned just now, we can do it by having a primary healthcare team in each of the clinic that we have in the government, in which they have a team A, team B, and team C, and each team will have a certain doctors that will actually in charge of certain population, or certain geographical population that will be in charge, so that they know their population well. And with this also we are able to turn good statistics in terms of which area are high in diabetes, or which area are high in hypertension. Okay? So of course, doctors alone are not enough. I think we also need, within the team, we need to have other multidisciplinary team, in which also I think we need to have, we actually having already integrated specialized services, in which the doctor will have the opportunity to refer to other like physiotherapy, medical social worker, of course the NCD educator. So we have a schedule for that. And one important thing is about care coordinator. We do not have care coordinator previously, because this is someone, care coordinator is very important, in which care coordinator can be someone non-medical, in which he or she will be the one communicate within the levels. Let's say, for instance, this patient needed this referral, then they will actually communicate with the care coordinator in the secondary and tertiary care, to allow seamless referral and also seamless communication between primary and the secondary and tertiary care. So I just go through very fast here. With this, the role of core coordinator aim to improve the continuity of care, as I mentioned just now. And regarding the finance part, so as I mentioned earlier, we do not have a national health financing system at the moment. So what we do is we have this Protect Health Corporation Sdn Bhd, So the government, this is actually a wholly owned subsidiary of Protect Health Malaysia, which is actually established as a company established under the Ministry of Health. So the aim of the company is not for profit company, but aim is actually to coordinate and to administer and also to manage initiative related to financing healthcare services as mandated by the Ministry of Health. So which means this Protect Health is the main role is actually like strategic purchasing to purchase services from the private side. So this on the right hand side, there are a few types. So I think we can focus on the Perubatan Madani and also the PKB40. PKB40 is actually focused on the screening, patient screening, health screening, and whereas for the Perubatan Madani, which means that it's Madani Health, it's actually referring to buying services for patient to have acute to have the general practitioner on the private side to see them for acute illnesses, so like upper respiratory tract infection and so on and so forth. Okay, so this is just in detail. If you can see, so far I think up to December 2024, we have actually more than 6.43 million who actually screen this PKB40 for health screening by the private side, in which the government buys services from the private side. Okay, and then for the Perubatan Madani, is a Madani healthcare, in which for the so-called again for the acute care for treatment of minor illnesses, you can see the top 10 diagnoses is upper respiratory infection, fever, and so on and so forth. So basically, each household will be allocated some money by the government for them to purchase services by the private general practitioner. So, and the last initiative that I want to share is actually the Rakan KKM. It actually means Rakan is in Malay. So KKM is actually Ministry of Health. So Rakan means Friends of KKM. So it's actually upgrade from because we are a government entity. So some patient, most of the our patient are actually from the below 40. It means that if you see the those who are actually poor, below 40. So and some patient also, we have patients who are actually from the middle class and also upper class, also coming to the Ministry of Health clinic to get the services. Because of that, I think the Ministry of Health actually introduced this a partnership in which the government clinic or government hospital are allowed, to have this section in which they can actually what we call, it's something like private wing of the private wing in the Ministry of Health, but actually the private is not fully private, in which they can actually partner with other government-linked company to have some services there, in which the aim is actually to increase the retention of healthcare workers, because as I mentioned, a lot of our healthcare workers are going to private sometimes because they want to have a better income, and they want to, at the same time, they want to raise the floor, especially for the below 40. These are the below 40 patient, and then and M40 is the middle income patient. So basically, all in all, it offers a premium economy services at the selected public hospitals, and as well as the clinic. So this has been just recently started last year, and actually is still ongoing. So I think that summarized my presentation. So these are the few references I used. You can actually access from online. You can just type in online. You can have a full document from the website. So with that, I thank everyone.
Thank you, Dr. Wong Ping Fu. That's a lot of information. I think you introduced us the whole picture of the primary care evolution and then the future plan of Malaysia. Yeah, so I think that's pretty impressive. And most impressed by there are so many free screening programs in Malaysia in primary care settings. Yeah. Like you say, we need to put them together to be more universal. Yeah. And I have a question. Is there any financial incentive for physicians to make their patient healthier? Will you have more income if your patients is healthier than other physicians patients?
Yeah. Thank you, Ping Shun. I think that's very good idea. At the moment, we are actually finalizing the implementation. It's already in the pipeline. It's just that we have not really implemented that because we need to think of the mechanism of payment and how to measure and what to measure. So yes, it will be in the next few years.
Okay. Thank you.
Yeah, not only for patients, but not only for doctors, but it's also for patients. Patient also will get some incentive. Yeah. Thank you.
Okay. Any other questions from the audience? Okay, Dr. Nico, please.
Hello, thank you. I'm Nico from Indonesia, and now I'm practice in rural area 5 years. So Malaysia and Indonesia is two country. I think it's like the same maybe. So I just want to ask you about. I heard that in Malaysia, change from sick care to healthcare and do transformation in primary care. What I ask is, in Malaysia, what the difference between family medicine specialty and GP gitu? Cause in Indonesia, sometimes we see it's not different from GP and family medicine gitu. So my question is, what the difference between a family medicine specialty and GP in Malaysia? Gitu. Okay, thank you.
Thank you, Dr. Nico, for the question. It's actually for Malaysia, GP is a very loose term that we use for doctors, primary care doctors who are in the private sector of primary care side. So of course, I think in Malaysia, unlike other countries, when you say GP in Australia, you are referring to a specialist. But in Malaysia, when you say GP, it's not a 100% specialist. But we also do have GP in Malaysia who are actually a specialist in primary care or family medicine specialist. So of course, that will be referring down to the national specialist register that we have. If they are registered there, then we will know that that particular GP is actually a specialist. So up to now, we have produced many private general practitioner who are actually in the program. So the numbers are increasing. So we hope that in many years to come, all general practitioner, when we say a general practitioner in Malaysia, they are actually specialists. Yeah. I hope that answered your question, Dr. Nico.
Yeah, I can say that in Taiwan, the situation is very similar to Malaysia. The GP is composed of some family medicine and some other specialty physicians. As long as they are working at the front line, the first line of primary care, they can all be counted as GP. And for family medicine, I think the training for family medicine is that it will be aimed to that we can take cover of about over 90% of diseases. So if we can take over some specialist patients, about at least 30 to 80%. The specialist patients we can take care of. Only the most difficult ones will be referred to a real specialist to hand over. Yeah, I think that's the purpose of family medicine training. Yeah. Okay, next we'll go to a speaker outside Asia Pacific region, Dr. Ana Perez from Mexico. She was with high specialty medical medical family therapy, working in a family medicine clinic of the Institute of Security and Social Services of. Sorry, my kids are crying. 等一下。Institute of Security and Social Service of State Workers in Mexico City, member of WONCA Young Medical Liaison at WONCA Working Party on Mental Health, member of the CIMF community and the Mental Health Working Group. Let's welcome Dr. Anna Perez for the next topic. Thank you.
I'm sorry. Can you hear me? Okay.
Yes, loud and clear.
Okay, thank you. Thank you for the amazing introduction. I'm Dr. Ana Perez from Mexico. It's my pleasure to be here. Thank you for the invitation. And good morning, good afternoon, or good evening, according to your time zone. Okay, as I mentioned, I am a family young doctor from Mexico. I will briefly talk about the Dr. Jose Eleuterio Gonzalez University Hospital, where I studied the specialty. It is one of the largest tertiary hospitals in the north of the country, located in the city of Monterrey, belonging to the state of Nuevo León. This is relevant because Mexico is a country with a wide territorial extension. The majority of family doctors are trained on the public health institutions. Although, in general, we all maintain knowledge about the family but during my residence, I experienced an even deeper knowledge of it and learned to carry out interventions throughout work with families. Techniques that are carried out in daily actions only at this location. Due to the time constraints, I will be very brief in mentioning what is being done, so I apologize if I am very punctual in my explanations. Thus, we begin with the question, what is working with families? Well, working with families allows us to focus on the management of the medical and psychosocial problems of patients and their families through our systemic and biopsychosocial vision. I can define it as the set of medical diagnosis, treatment, prevention techniques, plus techniques taken from medical family therapy, group management, pedagogy, and others, which allows the vision of the consultation to be expanded. There are some indicators that should be considered when choosing patient candidates for working with families. These are in two sections. The first is individual indicator, as hyperfrequenters, consultant for vague or non-specific symptoms, emotional, behavioral of relationship problems, poorly controlled chronic patients, poor adherence to treatment, multimorbidity, stage change in the individual life cycle, caregivers for a sick family members. And there is too some familiar indicators as unexpected change in family compositions, like birth, addition of family or friends, running away from home, death. Another one is a stage change in the family life cycle, crisis, addition, loss, morality status, conflicts in interactions between the couple or between family members, hospitalization of any of the members, start of the therapeutic program that encourage family involvement, families with a non-competent members, like in physical way or mental way, families with a terminal ill person. This also highlights the importance of understanding why there are two conditions of the family doctors that are essential. First, we are an expert in working with families, obviously. Our work is based on principles of systems theory, human communication, crisis and attention skills, and individual and family development. By being experts in these areas, we are able to identify those who require this work with families in any area in which we maintain contact with our patients. For example, in an emergency room, a child suffers from asthma and his attacks increase when his parents are even in the emergency area. Those who arrive for chronic pain or those who present chest pain in a stressful situation and have attended in the emergency service on multiple occasions, setting the tone for thinking about the need to find this cause throughout the study of various situations. Families that require support in understanding their pathology, families that face a disability as a side effect of a chronic illness or abruptly after an accident. Additionally, we can add those patients who present mental health problems caused by circumstances related to normative or paranormative crises. In addition, the family doctor visits his patients who remain hospitalized, does not lose sight of their follow-up, and carries out interdisciplinary, transdisciplinary, and multidisciplinary work. Part of what I would like you to take away from this talk is the understanding that the family goes throughout different phases when facing, for example, a chronic illness, and in which the family doctor can perform different interventions such as detailed below. For example, family with chronically ill person goes through different phases. The first is disorganization, the second is recovery, and the third is reorganization. In disorganization, in this particular step, there are two things that can happen: reorganization or irreversible disorganization. The functions of the family doctor in this stage is to help the family assimilate the impact during the interviews. It is suggested to talk about the challenge that everyone makes following the diagnosis of the disease and how they feel about them. Respect your own time and confrontation characteristics. The intervention process in this part is: first, apply union or engagement skills such as active listening, availability, facilitating emotional expression, making the correctional between the identified emotions and the symptoms and physical signs of the disease. The second is evaluate the impact of the chronic illness throughout the challenge and how it affects the family group and each member. What change occurred after the crisis? How long did it take before to solve a problem? Are perhaps the most important aspects. Additionally, the family's ability to communicate the thoughts and feelings associated with the disease with others must be evaluated. Third, offer educations based on the family's questions and doubts about the disease. It is useful to remember use of common terms, avoid giving unsolicited information, especially prognosis and complications. The fourth is identify the response style, like emotional climate, emerging conflicts, structure, and stage of the family cycle. The last one is negotiate a follow-up program for the patient and family, which facilitates access to the family doctor and relevant, adequate, and reliable education. There are some other factors, I'm sorry, in the last slide that influence the meaning of chronic illness for the family. Some depend on its type of severity, for example, the curability, and it includes complications and aftermath. type of treatment, family ideology. There is a lot of myths and belief about the disease that we can clarify for the patient and for their families. In the recovery stage, there are some indicators that facilitate identification, such as greater involvement of a peripheral person in terms of the disease, its management, or both. The focusing, it refers about when someone else consults for minor illness or consult for other health problems or programs. This can help to distribute attention and tension. Remember system theory, that in this part it's so important. Requests for more information, search for information in other sources, reconnection with extended family and other resources in the social environment with or without the same problem. The characteristics in this the mobilization of the system, seeking a level of operation that allows greater maneuverability. In this phase, the opportunity to be effective as family physician is magnified, especially in two areas of work. The first is in education. This is about the disease and its management, since this moment is the time of greatest assimilation of learning, should include two groups of information. Information about the disease in terms of etiology, diagnosis, treatment, prognosis, relationship with lifestyles, which should teach the patient and their family. The second is the information provided by the patient's body sensations, like, for example, signs and symptoms, provided for him to take responsibility for his illness, supporting his autonomy, self-responsibility, and strengthening family boundaries. And this facilitates change in the structure of the family group by addressing its relation aspect, simulating the development of the capacity of encouraging personal projects. The next is the reorganization. In this part, family reorganization in the face of a crisis during chronic illness tends to first maintain or consolidate the previous structure of the family. That is functions and tasks that are maintained by the same people. And the second is a change that occurs in the level of family functionality with change in the process of assigning tasks or assuming functions. This can produce a more effective level for solving their problems, or a less effective level of solving their problems too. The primary function of the family doctor is to prevent risk to the family. The most effective way is anticipate these events and act as a resource throughout the crisis, throughout the illness, with a clear intervention scheme in activities and care objectives. In conclusion, family doctors' intervention have clear objectives, and there are basically three. One, to evaluate which dependence of obtaining information from the family and analyzing it to detect specific risks and health problems. And two, for attachment or union and the establishment of a doctor-patient family work relationship, for which we have our clinical effectiveness and skills, in the medical interview. And the final is for management, whose ultimate objectives to facilitate change in the family system that make it more effective in solving the their health problems. We know that many of us depend on the time we have to provide a consultation, but it is necessary to follow up with our patients, identify their needs, and be able to find a solution to the problems that afflict them. Dealing with the patients always reminds me of what Dr. Ian McWilliam, maybe all of you know him. but he said that about the map and the territory. It is important that we are able to identify that else them from their territory. We have the knowledge, the map, but each patient, each territory is different. And it is in these differences that we recognize and analyze to give each one options where they will find relief, regardless of the cause. Let us be attentive to working with families regardless of whether we identify them in the consultation, in the emergency room, or in any other area in which we are designated. Let's give our attention with all our sense. Thank you.
Thank you, Dr. Anna Perez. I think that brings us to the very core of family medicine. Yeah, today we talked about the international medicine and a policy about family medicine and the core value of family medicine. I think that's the multi-phase of the whole concept of the family medicine. Yeah, and I have a question. How many time will you spend on a specific patient with the problems that you sensed that a patient might have? How long will you allow yourselves to dig deep in one patient's family issue or like emotional or mental something like hidden problems? Yeah.
Okay. Oh, wow. That is a fantastic question. There is a difference attending a patient in this hospital, especially, and in a public health system. In a public health system, we only have 15 minutes to attend a patient, and it's so difficult. In my everyday practice, honestly, sometimes I need to require 30 minutes for one patient when I identify these situations or these special situations. But in this hospital that where I studied, we could have 40 minutes, 1 hour in a case all family needs to receive some specific indications like education, for example. When they have troubles to be caregivers, sometimes need more information or more attention to their mental health. Sometimes when the diagnosis is like, for example, cancer. Yes.
Yeah, I think that's a must communication between family medicine and cancer patients. Yeah, because the oncologist usually would just tell them about the diagnosis and treatment plans, and sometimes a little bit less concerned about their emotional change and the strategy of cancer treatment. Well, the strategy of cancer treatment may vary greatly in different family settings. Yeah, and I think that's a very important role for family medicine for family doctors. Yeah.
Yes, remember that when a patient receives the first time the diagnosis, like an oncologist disease, they begin to have a crisis, and then the first step is they can hear all the information, they can understand all the indications, and that's the best part for us, because when the patient comes with us, we can explain all the details that in that previous encounter with the oncologist, they didn't understand. And that's important. That's so important to be in count.
Maybe we can have like a research about the cancer patient with the good family doctor support and a cancer patient without a very good family doctor support. Maybe the prognosis will be a lot different. Yeah.
Yes.
Okay.
That's interesting.
Yeah. Okay. Thank you, Dr. Ana Perez.
Thank you so much.
Is there anyone else who have a question for three speakers? Cheryl, you want to say anything?
Hi, Vincent. I just want to say a big thank you to all the speakers tonight. It has been a great, very comprehensive presentation, and it's wonderful to know different healthcare models in different countries around the world, not just in Asia Pacific region, but also in Mexico. So I think the YDM collaborative webinar gives us a platform for us to share what is happening in our country and also to look at other people's system in other countries. So thank you very much for everyone's presence tonight.
Okay, thank you everyone.